Hey everybody, this is Dr. Guccione from the Academy of Online Radiology Education. Thanks for joining me for this month's blog, and before we begin, I'd like to take a moment to recognize the reviewers on the screen who have helped make this blog and project possible. Thank you. The first article I have for you this month was published in Radiology and is looking at non-alcoholic steatohepatitis and evaluation with ultrasound and shear wave elastography. So it was a prospective study that had 111 adults who had a liver biopsy for NASH and an ultrasound with shear wave elastography. They measured various things such as dispersion slope attenuation coefficient and shear wave speed, and they used the receiver operating characteristic curve for analysis, evaluating area under the curve. You can see in the table at the bottom of the screen using pathologic correlate for elastography findings. For dispersion slope, they looked at the inflammation grade, attenuation coefficient, the steatosis grade, and shear wave speed, the fibrosis grade, with the corresponding grades and area under the curve. The combined area under the curve for all three to diagnose NASH was 0.81. They concluded that shear wave elastography may be helpful for diagnosing and monitoring non-alcoholic steatohepatitis. This next article is also looking at shear wave elastography, but its use in diagnosing idiopathic nephrotic syndrome and in evaluation the treatment effects. So they had 120 patients with idiopathic nephrotic syndrome and a renal biopsy, and they compared this to 30 healthy control subjects. Young's modulus was measured in both the idiopathic nephrotic syndrome group and the healthy subjects, and compared to biopsy results. They also separated into patients who were steroid sensitive and those who were steroid resistant. For the results, they found that the Young's modulus was higher in the idiopathic nephrotic syndrome group and highest among the steroid resistant patients, both which were significant. You can see more details in the table at the bottom where they did ROC curve analysis, calculating the area under the curve for the idiopathic nephrotic syndrome group versus control using an optimal cutoff of 7.96 meters per second for a specificity of 93.3%, and the steroid sensitive versus steroid resistant groups using a optimal cutoff of 10.73 meters per second, which optimize a specificity of 77.9% and a sensitivity of 86%. For the next article, they looked at small renal tumors, which were smaller than 3 centimeters in size. They wanted to see if elastography could help differentiate these lesions. Specifically, they wanted to look at clear cell RCC, urothelial carcinoma of the renal pelvis, and other tumors to differentiate. So they had 35 patients with 37 tumors and a biopsy, which they compared to. They measured shear wave elastography values, and they also created their own ultrasound mode, which they called elastographic self-corrected contrast enhanced ultrasound, which was able to quantify these lesions. So what they found is that clear cell RCC showed high elasticity values, and urothelial carcinoma of the renal pelvis had lower elasticity values. Using this ultrasound mode that they created, they were able to differentiate between clear cell RCC, urothelial carcinoma of the renal pelvis, and other small, less than 3 centimeter tumors with a 94.6% accuracy. This next article I have for you is in the realm of interventional radiology. They wanted to see if contrast-enhanced ultrasound could help with celiac plexus neurolysis in patients with upper abdominal cancer pain. So celiac plexus neurolysis is a technique of injecting alcohol around the celiac plexus, which helps to relieve pain. So they took 35 patients with upper abdominal cancers and uncontrollable pain, which they defined as pain greater than or equal to 7 out of 10. Post-procedural pain was monitored after the neurolysis was performed, and additionally 3D contrast-enhanced ultrasound was used to monitor for neurolytic dispersion around the aorta using contrast mixed with the neurolytic. So what they found was that 80% of patients had immediate pain relief, 77% still had relief at 1 month, and 29.4% had pain relief at 3 months. They found the median to be 2.7 months of relief, and another important finding was that all patients who had pain relief had 90 degrees of neurolytic dispersion around the aorta, which they were able to monitor using the contrast-enhanced ultrasound. Next, I have a musculoskeletal ultrasound article for you, which is looking at hematomas and the ease of aspiration based on various factors. So they had 148 patients with 165 hematomas which were aspirated. They looked at various ultrasound and clinical characteristics, as well as the needle size when aspiration was performed. And what they found was that hypoechoic hematomas were the easiest to aspirate, and they were easier to aspirate than hematomas with all other echotextures combined, with an odds ratio of 3.64 and a p of 0.01. Importantly, they also found the hematoma age, location, and the needle gauge used were not associated with ease of aspiration. It's also important to point out that all 100 patients who followed up after aspiration had symptomatic relief. This next article is looking at subacromial subdeltoid bursal steroid injection. They wanted to see if there was a difference in pain relief from high volume versus low volume steroid injection. For high volume, they used triamcinolone, 1 milliliter, which is 40 milligrams, plus 9 milliliters of anesthetic. For low volume, they just used the triamcinolone but no anesthetic, so only 1 milliliter injection versus 10. So they had 136 patients who underwent injection using ultrasound guidance. And they did find that high volume injector predicted early pain relief, emphasis mine, with a p-value of less than 0.001. You can see the pain relief score for high volume versus low volume at different time points. For example, at 3 weeks on a 10-point scale, it was 2.2 versus 4.7. 6 months, 1.6 versus 2.5. And 1 year, 1.6 versus 1.8. These were statistically different with a p of 0.001, but you can see as time goes on the smaller difference between the high volume versus low volume. As a side point, they also looked at a cadaver to calculate the volume of the subacromial subdeltoid bursa, which they found to be 6.9 milliliters in their subject. This next article is a review article looking at musculoskeletal ultrasound techniques. It is fairly comprehensive, but they emphasize newer applications such as the use of ultra-high frequency transducers, the use of microvascular imaging in inflammatory and neoplastic disease, and elastography and musculoskeletal ultrasound. And finally, in head and neck imaging, this article is a meta-analysis which looks at inter-observer agreement using TIRADS amongst radiologists. So they found 7 studies with 927 patients, and what they found was that variability among radiologists using TIRADS in ultrasound was moderate and quantified at 0.54. Among thyroid nodule features, they found that calcification had the least amount of variability amongst radiologists at 0.71, and nodule margin had the most, 0.41. Other features they looked at were composition, echogenicity, shape, and echogenic foci, with decreasing degrees of inter-observer agreement. Alright, that's all I got for you this month. Again, thanks for listening. I hope this was helpful, and thank you for joining us at the Academy of Online Radiology Education.